In this video, we will review the adult bradycardia algorithm used in advanced life support. We will begin with the basic physiology of bradycardia and explain how a slow heart rate may affect cardiac output. We will then review the important bradycardia rhythms, including sinus bradycardia and the different types of atrioventricular block. After that, we will discuss how to distinguish stable from unstable bradycardia, how to recognize life-threatening features, when to administer atropine, when to use other medications, and when cardiac pacing is required. Finally, we will examine transcutaneous pacing and transvenous pacing in greater detail, including their indications, procedure, confirmation of capture, and potential complications. This video is intended for educational review and does not replace certified ALS training, clinical judgment, or local hospital protocols. Let us begin with the basic physiology. Cardiac output is the amount of blood pumped by the heart in 1 minute. Cardiac output can be described using the following formula. Cardiac output equals heart rate multiplied by stroke volume. Heart rate is the number of heartbeats occurring each minute. Stroke volume is the amount of blood ejected by the ventricle with each heartbeat. Therefore, if the heart rate becomes significantly slower, cardiac output may decrease, particularly if the heart is unable to compensate by increasing the stroke volume. However, this does not mean that every slow heart rate is dangerous. Some healthy people, particularly trained athletes or people who are sleeping, may have a heart rate below 60 beats per minute without any evidence of impaired circulation. The clinical importance of bradycardia therefore depends not only on the numerical heart rate, but also on whether the patient has adequate blood pressure, consciousness, and organ perfusion. Definition of bradycardia. Bradycardia is generally defined as a heart rate below 60 beats per minute. However, the ALS bradycardia algorithm is intended mainly for patients whose slow heart rate is producing hemodynamic compromise or who are at significant risk of deterioration. A patient may have a heart rate below 60 and remain completely stable. In contrast, a heart rate of 40 or 50 beats per minute may be dangerous in a patient with myocardial ischemia, heart failure, or impaired cardiac function. For this reason, treatment should be based on the overall clinical condition rather than the heart rate alone. A patient with suspected clinically significant bradycardia requires urgent assessment, cardiac monitoring, and an electrocardiogram to identify the underlying rhythm. Causes of bradycardia. Bradycardia may result from impaired impulse formation, impaired electrical conduction, or a reversible systemic cause. One possible cause is slow impulse generation from the sinoatrial node. The sinoatrial node is the heart's natural pacemaker. If it produces impulses too slowly, the patient develops sinus bradycardia. Another important group of causes is atrioventricular block. In an atrioventricular block, electrical conduction between the atria and the ventricles is delayed or interrupted. We will now briefly review the different types of atrioventricular block. First-degree AV block. In first-degree atrioventricular block, conduction through the atrioventricular node is delayed. On the electrocardiogram, every P wave is still followed by a QRS complex, but the PR interval is prolonged beyond 200 milliseconds. First-degree AV block does not cause drop beats, and it does not necessarily produce bradycardia. It is often asymptomatic. However, it may indicate disease of the conduction system or the effect of medications that slow atrioventricular conduction. Second-degree atrioventricular block, Mobitz type 1, is also called Wengebach block. In this rhythm, the PR interval progressively becomes longer with each heartbeat. Eventually, an atrial impulse fails to conduct to the ventricles, and the QRS complex is dropped. After the drop beat, the cycle begins again. Mobitz type 1 block often occurs at the level of the atrioventricular node. It may be caused by increased vagal tone, medications, or an inferior myocardial infarction. Some patients remain stable, but treatment is required when the block produces symptomatic or hemodynamically significant bradycardia. In second-degree atrioventricular block, Mobitz type 2, the PR interval generally remains constant. However, occasional P waves are suddenly not followed by a QRS complex. Unlike Mobitz type 1, there is no progressive PR prolongation before the dropped beat. Mobitz type 2 usually represents more serious disease within the His-Purkinje conduction system. It has a significant risk of progressing to complete heart block or ventricular standstill. For this reason, Mobitz type 2 is considered a risk factor for asystole, and early expert assessment and preparation for pacing are required, even when the patient appears temporarily stable. Third-degree atrioventricular block is also called complete heart block. In complete heart block, no atrial impulses are conducted to the ventricles. The atrial ventricles, therefore, contract independently of one another. P waves and QRS complexes are both present, but there is no consistent relationship between them. The ventricles are maintained by an escape rhythm originating below the level of the block. If the escape rhythm originates close to the atrioventricular node, the QRS complexes may be narrow. If it originates within the ventricles, the QRS complexes are usually broad and the rate is often very slow. Complete heart block with broad QRS complexes is particularly concerning because it may progress to asystole. Other reversible causes bradycardia may also be caused or aggravated by several reversible conditions. These include hypoxemia, myocardial ischemia or acute myocardial infarction, electrolyte abnormalities, hypothermia, hypothyroidism, increased vagal stimulation, and medication toxicity. Important medication causes include beta blockers, calcium channel blockers, digoxin or other cardiac glycosides, and certain antiarrhythmic medications. Electrolyte disturbances should also be considered, particularly hyperkalemia, although abnormalities of potassium, magnesium, or calcium may all contribute to rhythm disturbances. The underlying cause must be identified and treated at the same time as the heart rate is being stabilized. Stable and unstable bradycardia, the next step is to determine whether the patient is hemodynamically stable or unstable. A patient with stable bradycardia maintains adequate blood pressure, consciousness, and tissue perfusion despite the slow heart rate. A patient with unstable bradycardia has evidence that the slow rhythm is causing inadequate cardiac output. Possible clinical manifestations include hypertension, confusion or reduced consciousness, dizziness, syncope, ischemic chest discomfort, shortness of breath, pulmonary edema, acute heart failure, cold peripheries, or other signs of shock. If the patient becomes unresponsive and has no pulse, this is no longer simply bradycardia. The patient is in cardiac arrest. Begin cardiopulmonary resuscitation immediately and follow the appropriate cardiac arrest algorithm. Initial assessment: assess the patient systematically using the ABCDE approach. Begin by assessing and maintaining the airway. Evaluate breathing, respiratory rate, oxygen saturation, and the adequacy of ventilation. Give oxygen when appropriate, particularly when the patient is hypoxemic, and support ventilation if necessary. Assess the circulation. Check the pulse, blood pressure, capillary refill, skin temperature, and other signs of organ perfusion. Obtain intravenous access and attach continuous ECG, blood pressure, and oxygen saturation monitoring. Record a 12-lead ECG when possible, but do not delay emergency treatment in an unstable patient. Assess neurological status and look for altered mental status, syncope, or other evidence of reduced cerebral perfusion. Finally, examine the patient for reversible causes and review the medication history, recent symptoms, and relevant laboratory results. The current European algorithm recommends an ABCDE assessment, appropriate oxygen, intravenous access monitoring of ECG, blood pressure and oxygen saturation, a 12-lead ECG, and treatment of reversible causes. Life-threatening features after the initial assessment. Determine whether life-threatening features are present. In the 2025 adult bradyarrhythmia algorithm, these features are shock, syncope, myocardial ischemia, severe heart failure, and bradycardia occurring immediately after return of spontaneous circulation. Shock may present with hypertension, cold or clammy skin, reduced urine output, altered mental status, or other signs of inadequate organ perfusion. Myocardial ischemia may present as chest pain or as ischemic changes on the ECG. Severe heart failure may present with pulmonary oedema, severe breathlessness, hypoxia, or raised jugular venous pressure. When one or more of these features are present and are believed to be caused by the bradycardia, immediate treatment is required. Risk of asystole A patient may not currently have life-threatening features, but may still be a significant risk of progressing to asystole. The recognized risk factors include recent asystole, Mobitz type II atrioventricular block, complete heart block with broad QRS complexes, and a ventricular pause lasting more than 3 seconds. Patients with these findings require continuous monitoring, urgent expert assessment, and preparation for temporary pacing. A patient without life-threatening features and without an increased risk of asystole may usually be observed while the underlying cause is investigated and treated. Atropine, when bradycardia is accompanied by life-threatening features, administer atropine. Under the European ALS algorithm, the initial dose is 500 micrograms intravenously. Atropine is an antimuscarinic medication. It blocks parasympathetic or vagal activity on the sinoatrial and atrioventricular nodes. This may increase the sinus rate and improve atrioventricular conduction. After administering atropine, reassess the patient's heart rate, blood pressure, level of consciousness, chest discomfort, and signs of perfusion. If the response is inadequate, repeat 500 micrograms every 3 to 5 minutes, up to a maximum total dose of 3 milligrams. Adult doses below 500 micrograms should be avoided because small doses may produce paradoxical slowing of the heart rate. Limitations of atropine. Atropine is not equally effective in every form of bradycardia. It is most likely to be effective when the bradycardia is caused by excessive vagal activity or when the conduction disturbance is located at the atrioventricular node. It may be ineffective in Mobitz type II block or complete heart block when the block is located below the atrioventricular node. Current European guidance advises against atropine in patients with high-degree atrioventricular block and broad QRS complexes because it is unlikely to work and may worsen the block. Atropine should also not be given to patients with a transplanted heart. A transplanted heart is denervated and will not respond normally to vagal blockade. In these patients, atropine may cause high-grade atrioventricular block or sinus arrest. Aminophylline may be considered instead in selected patients with cardiac transplantation or spinal cord injury. If atropine produces a satisfactory response, continue monitoring the patient closely. A satisfactory response includes an improvement in heart rate, together with improved blood pressure, consciousness, symptoms, and tissue perfusion. Do not focus only on the number displayed on the monitor. The clinical response is more important. Continue to identify and treat the underlying cause. Also assess whether the patient has any risk factors for asystole. Even after initial improvement, a patient with Mobitz type II block, complete heart block with broad QRS complexes, recent asystole, or prolonged ventricular pauses may still require specialist assessment and pacing. If the response to atropine is unsatisfactory, call for expert help immediately. The patient may require second-line medication, transcutaneous pacing, or early transvenous pacing. Do not repeatedly administer medication while delaying preparation for pacing in a deteriorating patient. The choice between medication and pacing depends on the patient's condition, the underlying rhythm, available equipment, local protocols, and the availability of an experienced clinician who can insert the transvenous pacing wire. Second-line medications. Second-line medication options include isoprenaline and adrenaline. Isoprenaline may be started at 5 micrograms per minute and titrated according to the patient's clinical response. Adrenaline may be administered as an infusion at 2 to 10 micrograms per minute and titrated to achieve adequate heart rate, blood pressure, and perfusion. Dopamine is another possible alternative under some protocols. Glucagon should be considered when beta blocker or calcium channel blocker toxicity is suspected. Aminophylline may be considered for bradycardia associated with cardiac transplantation or spinal cord injury. The current European guideline describes a dose of 100 to 200 milligrams by slow intravenous injection in these selected situations. Glycopyrrolate may be used instead of atropine in some clinical settings and according to local practice. The original notes also mention dobutamine. Dobutamine is primarily an inotropic medication and is not a standard routine medication in the adult ALS bradycardia algorithm. It may be used under specialist guidance when severe myocardial dysfunction and low cardiac output are present. Treating the underlying cause. Medication and pacing support the patient temporarily, but they do not necessarily correct the underlying problem. correct hypoxemia and inadequate ventilation. Treat acute coronary syndrome or myocardial ischemia according to the appropriate pathway. Correct important electrolyte abnormalities, particularly severe hyperkalemia. Stop or reverse medications that are causing bradycardia when clinically appropriate. Consider glucagon for beta blocker or calcium channel blocker toxicity. In significant digoxin toxicity, seek expert toxicology or cardiology advice and consider digoxin-specific antibody fragments. In hypothermia, remember that bradycardia may be a physiological response to the reduced body temperature. Rewarming is the primary treatment, and pacing is generally not indicated solely for hypothermia-related bradycardia unless the slow rhythm persists after rewarming. Stable bradycardia. Patients with stable bradycardia and no immediate risk of asystole may not require urgent medication or pacing. Continue cardiac monitoring and perform a detailed evaluation to identify the rhythm and its cause. Review the patient's medication list. Assess for myocardial ischemia, electrolyte abnormalities, thyroid disease, hypothermia, and structural or conduction system disease. If a reversible cause is identified, treat that cause. If the bradycardia is caused by a non-reversible condition, such as chronic symptomatic sinus node dysfunction or advanced atrioventricular block, the patient may require a permanent pacemaker. The decision to implant a permanent pacemaker should be made following specialist cardiology assessment. Temporary cardiac pacing is a potentially life-saving intervention used to stabilize patients with severe bradyarrhythmias. It provides electrical stimulation to produce ventricular depolarization and cardiac contraction until the underlying cause is corrected or a permanent pacemaker can be implanted. There are two principal forms of temporary pacing: transcutaneous pacing and transvenous pacing. Transcutaneous pacing is rapid and non-invasive, but it can be uncomfortable and may be unreliable for prolonged treatment. Transvenous pacing is invasive, but usually provides more reliable and consistent pacing. Transcutaneous pacing delivers electrical impulses through large pacing pads placed on the patient's chest. The electrical current passes through the chest wall and stimulates the myocardium to depolarize and contract. It is used as an immediate temporary intervention in unstable bradycardia when atropine is ineffective, unavailable, or unlikely to work. It is also used as a bridge while preparations are made for transvenous pacing. There are no absolute contraindications when transcutaneous pacing is required as a life-saving intervention. However, the procedure should only be used when clinically indicated because it is painful and may produce significant skeletal muscle contraction. When transcutaneous pacing is activated, narrow vertical pacemaker spikes appear on the ECG. However, the presence of pacemaker spikes alone does not mean that the heart has been successfully paced. Electrical capture occurs when each pacemaker spike is followed by ventricular depolarization. On the ECG, this normally appears as a pacemaker spike followed by a broad QRS complex and a T wave. It is important to distinguish a genuine paced QRS complex from electrical or muscle artifact. The presence of electrical capture must then be followed by an assessment for mechanical capture. Mechanical capture means that the electrical stimulus has produced an actual myocardial contraction and effective blood flow. Mechanical capture may be confirmed by detecting a palpable pulse that corresponds with the selected pacing rate. It may also be confirmed using a pulse oximetry waveform, an arterial blood pressure waveform, measurable blood pressure, or ventricular contraction seen with point-of-care ultrasound. Electrical capture does not always produce mechanical capture. A monitor may display a paced QRS complex even though the heart is not generating an effective contraction. For this reason, never assume that pacing is successful based on the ECG alone. Confirm both electrical and mechanical capture. Applying the pacing pads. Prepare the patient's chest and apply the pacing pads according to the manufacturer's instructions. An anterolateral position may be used, with one pad on the right upper chest and the other over the left lateral chest. An anteroposterior position may also be used, depending on the patient, the device, and the clinical situation. Avoid placing pads directly over an implanted pacemaker or defibrillator. Connect the pads to the defibrillator or external pacemaker. Attach the ECG monitoring leads if they are required by the device. turn on the machine and select the pacing function. Sensing the intrinsic rhythm. Before beginning pacing, confirm that the pacemaker is correctly sensing the patient's intrinsic QRS complexes. When demand pacing is used, the pacemaker delivers an impulse only when it does not detect an intrinsic ventricular beat within the selected interval. Poor sensing may result from incorrect lead placement, inadequate ECG signal, movement artifact, or inappropriate sensitivity settings. Movement artifact may falsely inhibit pacing. If demand pacing is unreliable because of significant artifact, fixed rate pacing may be required according to the device and clinical circumstances. Selecting the pacing rate. For most adults, a rate between 60 and 90 beats per minute is used. An initial rate of approximately 60 to 70 beats per minute is often reasonable, although the precise rate should be adjusted to the patient's hemodynamic response. The goal is not simply to produce a normal number on the monitor. The goal is to obtain adequate cardiac output, blood pressure, consciousness, and tissue perfusion without producing an unnecessarily rapid heart rate. Increasing the pacing current. Begin with a low current output when the patient's condition allows, and gradually increase the current while observing the ECG and the patient. Increase the output until every pacemaker spike is followed by a broad QRS complex, indicating electrical capture. Transcutaneous capture often requires approximately 50 to 100 mA, although the required current varies considerably between patients and devices. Once electrical capture is present, confirm mechanical capture by checking the pulse, blood pressure, pulse oximetry waveform, arterial waveform, or cardiac contraction on ultrasound. After determining the capture threshold, set the current approximately 5 to 10 mA above that threshold to reduce the risk of losing capture. If the maximum output is reached without capture, reassess pad placement and consider changing the pad position. Pacing a peri-rest patient. In an unconscious, severely unstable or peri-rest patient, there may not be enough time to increase the output slowly. In this situation, high output or maximum output pacing may be used initially to achieve capture as rapidly as possible. Once capture is obtained, the current can be reduced until capture is lost. This identifies the pacing threshold. The current should then be increased again and maintained approximately 5 to 10 mA above the threshold. Continue to assess the patient continuously because electrical or mechanical capture may be lost during movement, transfer, or clinical deterioration. Analgesia and sedation. Transcutaneous pacing is often very painful in conscious patients because it stimulates the chest wall muscles as well as the heart. Provide appropriate analgesia and procedural sedation when the patient is conscious and hemodynamically able to tolerate it. However, sedation must not delay life-saving pacing in a rapidly deteriorating patient. Sedative and analgesic medications may reduce respiratory effort and blood pressure. Therefore, continue frequent ABCDE reassessment and be prepared to support the airway and ventilation. Complications of transcutaneous pacing. Potential complications of transcutaneous pacing include significant pain and skeletal muscle contractions. Prolonged pacing may cause irritation or burns beneath the pads. Electrical or mechanical capture may be lost. Pacing can occasionally provoke ventricular ectopic beats or more serious tachyarrhythmias, including ventricular tachycardia or ventricular fibrillation. Stimulation of the diaphragm may cause coughing or hiccups. In some patients, ventricular pacing without coordinated atrial contraction may reduce cardiac output and produce symptoms resembling pacemaker syndrome, such as dizziness, palpitations, hypertension, or syncope. These risks reinforce the importance of continuous ECG and hemodynamic monitoring. Transvenous pacing involves inserting a pacing electrode through a central vein and advancing it into the right ventricle. The electrode is connected to an external pulse generator that delivers electrical impulses directly to the endocardium. Because the electrical stimulus is delivered directly to the heart, transvenous pacing normally requires much less current and provides more reliable capture than transcutaneous pacing. It is commonly used as a temporary measure until the underlying conduction abnormality resolves or a permanent pacemaker can be implanted. Transvenous pacing may be required in patients with persistent, symptomatic or unstable bradycardia that does not respond adequately to medications. Important indications include symptomatic sinus node dysfunction, Mobitz type II atrioventricular block, and complete heart block. It may also be required in atrial fibrillation with a dangerously slow ventricular response. Temporary transvenous pacing may be necessary when an implanted pacemaker or other cardiac electronic device malfunctions. It should also be considered in patients with recent asystole, prolonged ventricular pauses, or conduction disease associated with a high risk of progression to ventricular standstill. In selected specialist situations, transvenous pacing may also be used for antitachycardia or overdrive pacing. This is separate from the standard bradycardia algorithm. Current European guidance recommends early transvenous pacing for unstable symptomatic bradycardia that is refractory to drug treatment, with transcutaneous pacing used as a bridge when necessary. Contraindications and special considerations. A prosthetic tricuspid valve presents an important limitation because a conventional transvenous pacing wire must normally pass through the tricuspid valve to enter the right ventricle. Passing a wire across a mechanical prosthetic tricuspid valve may damage the valve or interfere with its function. An alternative pacing approach may therefore be required. Severe hypothermia also requires special consideration. Bradycardia in severe hypothermia may be physiological and may improve with rewarming. Routine pacing is generally not indicated solely because of hypothermia related to bradycardia unless the rhythm remains clinically significant after rewarming. The risks and benefits of transvenous pacing must be assessed by an experienced clinician. Complications of transvenous pacing. Transvenous pacing is invasive and may cause complications related to both central venous access and the pacing electrode. Vascular access complications include bleeding, infection, arterial puncture, hematoma, venous thrombosis, air embolism, pneumothorax, or hemothorax. The pacing wire may irritate the myocardium and trigger ventricular ectopic beats, ventricular tachycardia, or ventricular fibrillation. The wire may perforate the right ventricle and cause a pericardial effusion or cardiac tamponade. The electrode may become displaced, resulting in intermittent or complete loss of capture. Other potential problems include failure to sense intrinsic cardiac activity, failure to pace, damage to the wire, or disconnection from the pulse generator. The patient therefore requires continuous ECG monitoring, regular assessment of the pacing threshold, and frequent confirmation of mechanical capture. Let us now summarize the complete adult ALS bradycardia algorithm. First, assess the patient using the ABCDE approach. Give oxygen when appropriate. Obtain intravenous access and monitor the ECG, blood pressure, and oxygen saturation. Record a 12-lead ECG when possible and identify reversible causes. Next, determine whether life-threatening features are present. These include shock, syncope, myocardial ischemia, severe heart failure, and bradycardia immediately after return of spontaneous circulation. If life-threatening features are present, administer atropine 500 micrograms intravenously. Assess the response. If the response is satisfactory, continue monitoring, treat underlying cause, and assess the risk of asystole. If the response is unsatisfactory, repeat atropine every 3 to 5 minutes to a maximum of 3 milligrams. Seek expert help and consider isoprenaline, adrenaline, alternative medication, transcutaneous pacing, and early transvenous pacing. If life-threatening features are absent, assess the risk of asystole. Risk factors include recent asystole, Mobitz type II block, complete heart block with broad QRS complexes, and a ventricular pause longer than 3 seconds. Patients without these risk factors may be observed while the underlying cause is investigated. Patients with a significant risk of asystole require close monitoring, expert assessment, and consideration of temporary pacing. Bradycardia is defined as a heart rate below 60 beats per minute, but treatment is determined by the patient's clinical condition rather than the heart rate alone. The most important step is to recognize whether the slow rhythm is causing hemodynamic compromise, assess the patient systematically, identify life-threatening features, treat reversible causes, and recognize rhythms associated with a risk of asystole. In the European ALS algorithm, atropine 500 micrograms intravenously is the initial medication for unstable bradycardia, repeated when necessary to a maximum total dose of 3 milligrams. When atropine is ineffective, prepare for second-line medication and cardiac pacing without unnecessary delay. Always confirm both electrical and mechanical capture during pacing. Thank you for watching. This video is intended for educational review only. In clinical practice, always follow your local protocols, hospital guidelines, medication policies, and certified ALS training.